Now we are going to continue and moving into the Pecha Kucha session. So Anand Ben was supposed to be chairing this session, but unfortunately he couldn't make it to this meeting. So I am today a small Anand, and my real name is Paul Ndebele, and I'm working at the George Washington University in the School of Public Health in Washington, D.C. I'm also serving as a member of the GW IRB. So we're now getting into this session where our colleagues here are going to present in a rushed fashion. There are 20 slides?
Yes,
15 slides?
Yes.
15 slides with 20 seconds per slide. Okay, so we're going to move straight into our first presenter. So our first presenter is Meshandren Naidoo from the University of KwaZulu-Natal in South Africa. That's my university. Yay! So the topic is a shift to openness, open consent, and open science in AI health research in South Africa. Over to you.
Okay, this is going to be quick, guys. So just try to keep up. Okay, yeah? Oh, is that what I look like? Oh. Okay, a shift to openness, open consent, and open science in AI health research in South Africa. So what I'm looking at is more research-friendly model of consent, namely open consent. Here, one consents to a lesser extent of privacy in their personal data, namely it being freely and openly available for all. The Harvard PGP piloted this, and while there are laws that are different here, we can possibly adopt a SA-specific model that serves our context, perhaps a modified semi-open consent model. From a legal perspective, South Africa has various laws and guidelines intended to govern health research in the country. I will deal with the following briefly: the South African Constitution, the National Health Act, and PPR, followed by the concept of open consent within the open science framework in South Africa. The South African Constitution, I can only hope that my slides are with me. All laws derive their power/mandate from the Constitution. They also must be in line with the Constitution. It has its own jurisprudence, and at its very core, it contains metaphysical considerations which form the basis of things like dignity, autonomy, freedom. Like the metaphysical conception of personhood, which is enlightenment-based Kantian, we are people because of our rationality. Now, this doesn't really lend itself well to the African conception of personhood. Anyway, the National Health Act. The National Health Act provides a statutory authority for the governance of health research and research ethics infrastructures. It does not really speak to the mode of consent required, but does require that there must be written consent for human biological material. The Department of Health Ethics guidelines were a primary guide for health researchers in South Africa and were made legally binding by the Human Research Participant Regulations. These regulations, in terms of the National Health Act, require that information must be communicated as part of the consent processes. Participants in research must be informed of the purpose of the research. Thus, of course, the research must have an identifiable purpose, which seems to exclude blanket consent. Perhaps, though broad consent is possible, these regulations, although require that research with human participants, must comply with the ethics guidelines. This is a subsidiary law. Oh goodness, I'm still on track. These guidelines are legally binding on research institutions and researchers. Unfortunately, these guidelines were heavily influenced by the H3 Africa, which is problematic because it doesn't have any democratic mandate in South Africa. And it is just a partnership between groundbreaking institutions and researchers. These guidelines reject blanket consent and instead list narrow consent, tiered consent, and broad consent as acceptable. PPR, which is primary legislation, governs laws and ethics structures in the country. Consent here in PPR is specific, voluntary, and informed. The inclusion of specific consent here complicates things a little bit because specific consent is not really defined. So if we apply our general principles of statutory interpretation, there remains disagreement as to its content. A restrictive approach wouldn't really be allowed, but perhaps there is room for a broader interpretation which would allow open consent. Okay, the draft code of conduct doesn't really speak to consent so much other than the fact that they want to safeguard consent. Okay, oh yay. Okay, so we have an open science framework in South Africa. So the thing that I'm really relying on is the fact that we want to have better access to data. And the South African government has really shared this by enacting various policies and different bodies that really speak to government regulation in this area. Oh, sorry, I forgot there's this thing here. You know, this nervous energy is just flowing all the way through me. Okay, so potentially if we're speaking about open science, like I mentioned, open consent might actually fit within that framework quite well. I haven't really spoken about so much about open consent, but it really entails individuals openly donate and share their data for research. Further, to ensure that consent is informed, open consent requires participants to take and pass an examination to test their understanding. Thus, open consent can be perceived as an attempt to marry open science and the benefits associated with it, so informed consent. Is open consent supported by the Constitution and jurisprudential values in Southern Constitution? Perhaps so, simply because we have various jurisprudential values that speak to openness of data. For example, freedom of scientific research. If you really want an answer to this question, which I cannot provide, you can read Amy's thesis, which will be ready in a year, where she explores this topic in great detail. And to conclude, is open consent contradicting PAPIA? Well, it really depends on how specific consent is defined in PAPIA, which we don't really know. If you look at the framework, perhaps yes, perhaps not, the classic legal answer. And yeah, I think I'm done. I'm very tired. Goodbye. Can
you repeat that?
And I was just thinking, Popia. But what did he eat during lunch? Or what did he drink? I wonder. That was an energetic presentation. So thank you so much for that great presentation. And the next presenter is going to be Derrick Aarons, all the way from the Caribbean Public Health Agency in Jamaica. And we're going to talk about a regulatory framework for AI health research in the Caribbean. Over to you, Derrick.
Thank you, Paul. Artificial intelligence algorithms will be used to detect a number of illnesses and diseases. But to protect the participants in research endeavors, robust and appropriate regulations should occur for AI research, and this should be implemented across all Caribbean countries. In 2015, the Caribbean Public Health Agency presented to the Ministers of Health in the Caribbean community a green paper proposal to regulate the conduct of research to protect the inhabitants within the region. However, this draft legislation is yet to be written. Further, with the current accelerated use of AI in the collecting and processing of health data for research, and its discovering associations in health data, and its use in assessing impacts for interventions in health, Research Ethics Committee members will need update in this regard. Currently, there are 23 Research Ethics Committees across the Caribbean, and most do not have the AI expertise or experience to conduct an appropriate risk-benefit assessment, evaluate the models of consent appropriate as presented by researchers, and assess any complex algorithms to be used in the AI health research. Consequently, the proposed draft regulations to be written for Caribbean region should be updated to require Research Ethics Committee members to undergo annual updates, training to keep up to date and abreast of new developments. At these update training sessions, Research Ethics Committee members should be required to discuss particular challenges implementing AI in Caribbean research, including inadequate access to reliable and affordable internet and unreliable electricity supply infrastructure across many communities. Also, the inadequate human resources, too little education, and insufficient skills among the local populations, inadequate local investments, and the risk of job losses that AI and automation may produce. These deliberations will provide better insight when research protocols are being evaluated. The new regulations should also address the specific challenges posed to consent, privacy, and security, and the power imbalances existing between the AI data collectors and research participants to engender public trust in the research endeavors. In addition, the regulations should stipulate the need for public engagement in all research projects by requiring the involvement from the conceptual stages of community representatives and representatives from vulnerable and marginalized groups where the research may involve them. The community representatives would assist in informing on the design of the research, in identifying and mitigating unforeseen risks, in assessing possible local and community benefits, and in facilitating transparency. With the expansion of the scope of these draft regulations in seeking to protect not only individuals and their interests, but also to balance the risks and benefits to the society, a more robust, if not comprehensive, research ethics framework would have been facilitated. This comprehensive research regulatory framework that I'm recommending to the countries of the Caribbean would address the new realities and challenges posed by the use of artificial intelligence in health-related research. Consequently, it is now opportune to update the model draft legislation for the countries of CARICOM, which was approved in 2015, to be prepared by the legal draftsmen at the CARICOM headquarters in Guyana to address many of the new ethical issues posed by AI in health research. This following slide is a summary of the Green Paper proposal that was made to the Caribbean Ministers of Health in 2015, which was approved unanimously for implementation, but not yet enacted, now 7 years later. This needs to be done for us in the Caribbean. And these are my references, and I thank you for your kind attention.
Thank you very much, Derrick. In the Caribbean, would say this was cool. Wonderful. So we're now going to move on to our next presentation, and the title is How to Translate Universal Principles to Local Realities. And this is going to be the Chilean experience on AI. And we have no one other than Sofia, Salas from Clínica, Alemana, Universidad del Desarrollo de Chile.
Thanks, Paul. May I have the first slide? Oh, sorry. Thanks to the organizers of this meeting for giving me the opportunity to attend this important forum after a 2-day-long flight. I will discuss the Chilean experience in elaborating an artificial intelligence guideline as a proposal to translate universal principles into local realities. I will focus on 4 main topics. I will discuss some lessons obtained from the Moral Machine experiment. Then I will give a critical appraisal regarding current guidelines. I will discuss the Chilean experience in writing its own AI guidelines, and I will finish with some recommendations. The computer brain of a self-driving car has the ability to learn and make decisions based on experience. Key question is whether the driverless car should keep the baby or the grandma, as a modern version of the old trolley dilemma. Ethical questions such as these challenge the development of these vehicles. In 2018, Awad set up an online platform where he obtained decisions from millions of people in different countries. They were presented with scenarios about what should the self-driving car do. The data generated provided insight into the collective ethical priorities of different cultures. Although there were strong preferences for sparing human lives, there were considerable differences across countries. For example, participants from the South spared those with a higher status, suggesting that humans experience cultural dissimilarities in the moral domain, making it difficult to have a universal moral code. With respect to the challenges of machine ethics, there is consensus regarding some important principles. However, the way how these principles are implemented in different settings need to be addressed locally according to the culture and context where AI is deployed. In different areas of research, it has been documented that researchers from the Global South are underrepresented, even when the focus of the paper is based on this region. Likewise, most of the present guidelines on AI are written by specialists from the Global North. This South-up roadmap emphasizes that being in the South can influence how we look at these moral issues. Although there is a global convergence around ethical principles, there is substantive divergency in relation to how these principles should be interpreted across different countries. The Chilean initiative is aimed to have local standards on the development and use of AI. To elaborate this national policy, the Chilean National Council of Innovation for Development organized several initiatives to develop our own guidelines in order to position the country as a world hub for data science. To develop this policy, there were meetings in each of the country's region and several workshops in which AI was examined from multiple perspectives and disciplines. Additionally, there was a public consultation process. After a thorough analysis, the first Chilean AI policy was launched in 2020. The policy is based in 4 principles, focused on the well-being of people, sustainable development, inclusive AI, and globalized AI. Moreover, every action related to AI must be approached in an interdisciplinary manner. This policy has 3 main axes: enable factors, focuses on the development of talent and technological infrastructure. Development and adoption include basic and applied research. Ethics and regulatory aspects, including discussions around human-machine interaction and gender issues. I would like to emphasize the importance of diversity, on adequate team performance, and on developing guidelines that will have local acceptance. As shown by the Chilean experience, it is possible to have broad participation in the development of new guidelines, including groups that have been historically relegated. An example of the responsible use of AI is the recently launched project Irene Salud. The integrated risk examination for the new elderly estimated the risk of loss of functionality in older adults. The predictive model was developed using AI and machine learning methods. In conclusion, it is important that these policies take into account the nation's own cultural and social values, and also the singularities and challenges of the country, avoiding value imperialism. As shown by the Chilean experience, this is possible. Thank you very much.
We were in Chile. Now we are going to cross over to Africa. And we have Oluchi, who is going to talk to us about developing a governance framework for data science health research in Nigeria. Over to you.
Hello, good afternoon. My name is Oluchi Maduka from the Center for Bioethics and Research, Nigeria. I'll be speaking to you on an overview of the governance framework for data science health research in Nigeria. So in 2021, with funding from the NIH, we began to look at, under the DSI Africa Consortium, we began to look at the ethics of data science health research in Nigeria. The project is called the Bridge LC, acronym for Bridging the Gaps in the Ethical, Legal, and Social Implications of Data Science Health Research. Here are the other members of the team. That's my beautiful portrait there. So we are looking at data science. Data science has enormous implications for healthcare. However, it raises a lot of issues. that we have been discussing for the past 2 days on the content and quality of consent, ownership of data, privacy, benefit and harms to individuals. And no, these issues are particularly important for LMICs like Nigeria, where regulations are evolving. And now at the Bridge LC project, what are we doing? We are looking at the existing governance framework as a foundation for the development of novel governance framework for data science health research in the country. We are looking at the existing laws. What do these laws say? How can they be improved? What can be done? And what are the gaps? So the Bridge LC project has several components. We are looking at the existing laws. We are also doing a survey, the knowledge, attitude, and practices of stakeholders to the current and emerging LC of data science health research. We're also engaging stakeholders. We are talking to a lot of people to develop this novel governance framework, and we're implementing training and mentoring in data science health research and general capacity building for data science health research. So what I'm talking to you about is the result of the specific M1. That is the methodology we used for the specific M1. It's purely a legal research, case law analysis, text analysis. We relied primarily on primary and secondary data, and we identified specific themes that are common in data science health research. Now, we first of all, we identified some questions, which are, what are these laws that provide framework for data science health research in Nigeria? And are these laws sufficient? For example, do they answer questions about the identified health data, secondary use of health data, commercialization of data, tissue, and then what are these gaps? And then here are the themes that were common in some of these laws that we looked at. The issue of discrimination, ownership of data, transfer. Do they protect communities, cultures, and groups? Because we considered what AI can do, it can cause harm. The identification of data, informed consent. And then this is the extant governance framework we looked at. Legislation, case law, regulations, guidelines. And then what has been missing from our discussion for the past 2 days is the role of case law. These laws that we have, how are the courts interpreting it? And now in Nigeria, we are seeing insight. Courts are saying even pictures, things that are publicly available, the courts are saying you need the consent of the owner. And now these are some of the questions, how these laws address these questions. And now if you look at the National Code of Health Research Ethics, it's the framework that responded to some of all the issues that we raised. That is the framework that addresses health research governance in Nigeria. It applies throughout the federation. And then this second table, it is the themes and how the laws responded to some of these themes on the issue of consent, privacy, cultures, groups. You see that the laws address consent, privacy, rights of data subjects, dignity. Overall, Nigeria has a robust framework, data privacy and protection. The laws cover a whole lot of things: confidentiality, consent, participant, protection of cultures. However, there are gaps in the area of the identified health data, anonymized data, and publicly available data, how we use them for research. Recommendations. We are saying that there is need for the development of novel governance framework, which we are doing, that builds on existing laws and includes broad stakeholders' engagement, and it ensures protection of participants, researchers, and their products, and builds trust in the whole country. We acknowledge the support and staff of the Center for Bioethics and Research. 2 of our faculty members are here, and then we also appreciate the NIH for funding. Thank you.
I could see, Oluchi moving with us, flying across Nigeria from one state to the other. So thank you very much for that wonderful presentation. Now we are going to move on to our next presentation on adaptability of India's health data regulations. And our next presenter is going to be Rukanjali from the Duke University in the United States of America. United States of America in India.
Well, I have to acknowledge there is some technical glitch with my presentation, so just in case the slides freeze, may pardon me. Okay. I'll try to keep pace. Okay, start. So most of us would have heard about the laws of learning in psychology. Where did it go? Okay, yeah. But do the laws in legal and policy space, are they learning? So I attempted to understand this question by analyzing the laws and policies of India in health data sector. It's part of my doctoral research in which I used qualitative research methods to answer this question. Adaptive regulation enables regulatory learning. It's an iterative process of decision making where multiple sequential decisions are made based on new information and changing circumstances. On the other hand, static laws are designed at the outset to regulate for perpetuity, which are not suitable for complex situations which often demand flexible and nimble approach. There are the 6 broad features of adaptive regulation of making laws learn: assessing risk and uncertainties, broader and fuller impact assessment, monitoring and evaluation, iterative decision making. These are based on the systematic review of literature and are basically culled from the perspective of a learning-oriented decision-making process. I got it. So these 6 features are embedded in the form of an adaptive regulatory cycle, and each of the 3 stages have adaptive features in pre-implementation, implementation, and post-implementation. The cycle is a contribution of my dissertation research and is developed to depict the importance of adaptiveness in the life cycle of a regulatory process. I analyzed 6 federal law and policy documents of India, including the National Digital Health Mission policy documents, and based on content analysis, the policies show high presence of 3 adaptive features of monitoring and evaluation, iterative decision-making, and public participation, whereas it is low in the other 3. The interview analysis of 10 stakeholders suggests that interagency coordination indicates low prevalence in India, whereas iterative decision-making and public participation indicate high prevalence in practice, and the remaining 3 features indicate moderate prevalence in practice. Combining the document and interview analysis shows there are 2 features where the sector is more adaptive in practice than on the books, which are highlighted by blue rectangles, and 1 feature where it is less adaptive in practice than on the books, that is a red rectangle called monitoring and evaluation. And this is in sync with the interview analysis, which suggests that the policy revisions are not informed by formal policy evaluations. A very high-level comparison of health data law of US and India shows that the 2 countries are similarly adaptive in 2 features, that is assessing risk and uncertainties and iterative decision-making, but India is less adaptive than US in 4 other features. This could be attributed to the nascence of health data laws and policies in India. How the laws could learn better, I have developed a normative framework. This is where the slide is going to freeze. It has frozen. So this is based on the review of best practices. It will come, I think, in one go towards the end. The idea to show this slide was just that the research has been done to find what are the best practices recommended in each of the 6 adaptive features, because the next set of slides which are going for recommendations for India are based on the best practices which you just saw. So I have recommended an adaptive regulatory cycle for India to address the gaps highlighted in my research, primarily to make the regulatory process more consultative, to strengthen monitoring and evaluation of laws and policies, and similar regulatory cycle could potentially be useful for other low and middle income countries. For health data sector specifically, it is recommended that we should introduce structured decision-making processes like risk assessment and regulatory impact assessment. However, they should be suitable to the context, resources, and capacities of India. To address less structured and less transparent monitoring and evaluation, it is recommended that there should be prior planning of relevant data collection at the design stage of laws and policies, and monitoring and evaluation information should be put in public domain and also used to inform future lawmaking and to make policy adjustments. This is an iterative sector and a lot of changes are happening in practice. However, these policy changes are not based on planned evaluations. These are based on stakeholder feedback or learning from pilot programs, which are often not documented. Therefore, it's recommended that to improve regulatory learning, there should be more emphasis on formally evaluating the policy interventions and publishing the results and the methods deployed. And lastly, the gap of less interagency coordination in health data sector is based on both document and interview analysis, and it's recommended to strengthen existing interministerial consultation processes and conduct multi-agency policy reviews to improve cross-agency coordination. Overall, most of India's analyzed health data policies are still evolving. Therefore, before India begins to use AI in health research, it should create a more adaptive framework of health data policy so it can best learn and improve how AI is working and address any ethical issues which arise in the process of using AI in healthcare. Thank you.
Thank you for such a wonderful presentation. Now we know lots more about the landscape in India. So during this session, we were in South Africa and then went to the Caribbean and then went to Chile and then Nigeria and then India. A big applause for all our presenters.